begins around November. It peaks around February, March, and begins to decline before the end of April, May. So usually it's between November and May, and this epic curve gives us that idea. It's important to note that this kind of understanding of seasonality would not be possible without good surveillance data being reported, without good surveillance activities going on. So this is another example of the value of a good surveillance system and a proper notification and archiving of the data for such analysis. Move on. So generally speaking, surveillance is critical to the control of diseases such as Lassa fever. And Lassa fever control in relation to surveillance requires routine surveillance even when there are no outbreaks, so that we can detect cases early. There has to be early warning systems. There has to be trained personnel who can properly identify using case definitions and properly document and notify or report the next level for action. It could also be an enhanced surveillance system that is applied during emergencies like outbreaks. In that case, the surveillance must be active. There is no room for passive reporting during outbreaks. It actually should be active, and the enhanced model gives room for a lot of collaborations for data collation and information sharing. Also, for Lassa fever control, we require a coordination system for preparedness and response, right down to states and LGA levels. Usually at the end of an outbreak, or when the outbreak has declined significantly, we expect to do after-action reviews, which involve a lot of review of surveillance data. Furthermore, there must be better planning prior to the next outbreak season, as I believe has been going on at the national level and in many of our states. We are in November now, a season when the outbreak, the cases may begin to emerge again. So a lot of planning has started since about September, when we received September, October, when we received alerts from NCDC to the states. And some states, I believe, if not all, have been doing some contingency planning in preparedness for the outbreak season. It requires a lot of training and retraining. Whether there is attrition of staff or not, we will always need training and retraining. Simulation exercises will be helpful in many cases to prepare people for emergencies. And of course, in the case of Lassa fever, which is known to be zoonotic, as we will see in other presentations, we require a collaborative One Health approach to everything that surveillance can do to control Lassa fever. One Health, of course, involves environment, animal, and human experts to control the disease. Now, identifying cases in a surveillance system is based on case definitions. Case definitions are critical because it helps you to differentiate one disease from another, and it helps to minimize waste of resources and helps the surveillance system to be sensitive and to a very large extent specific. Now, there are three broad major case definitions applied for surveillance: the suspected case, the confirmed case, and the probable case. So the suspected case generally is any illness of gradual onset with any of the following symptoms: malaria, fever, headache, sore throat, cough, nausea, vomiting, diarrhea, myalgia, chest pain, usually central chest pain, which is just behind the sternum, sometimes hearing loss. Any of these symptoms of gradual onset could be pointing to Lassa fever. In addition to that, you could also have, next slide please, you could also have a history of contact with rodent excrements and a history of contact with a confirmed Lassa fever case or a probable case. within 21 days of onset of symptoms. It's important. The 21 days is an estimation of the incubation period. So within that period, if there is any history of such contact, there could also be a high index of suspicion for a suspected case of Lassa fever. And generally, we could say that because the spectrum of Lassa fever disease includes hemorrhagic symptoms, any person with unexplainable bleeding or inexplicable bleeding could be a suspected case. Let's move on. So furthermore, a confirmed case is simply a suspected case that has laboratory tests confirming the presence of Lassa fever antibody, usually done in specialized labs. Fortunately, we have a few more labs now and we can confirm cases. Probable case is any suspected case defined above, but who died without collection of laboratory specimen for testing. But generally speaking, clinicians need to have a high index of suspicion when managing acute febrile illnesses in Nigeria, because one of the common differentials, especially in hyperendemic areas, one of the common differentials for acute febrile illness could be Lassa fever. Yes. So generally, in managing outbreaks, again, we require surveillance data to help us to set thresholds. And generally, for now in Nigeria, we apply the alert threshold for Lassa fever to be a single suspected case. The moment you suspect a case, the clinicians raise that flag. Let's test this patient for Lassa fever. We are suspecting we've done this or that, and we think that Lassa fever is high on our differentials. We are in an alert outbreak threshold. Yeah, an alert threshold rather. And the outbreak threshold would be once the case is confirmed. But furthermore, it's important to know that as we continue to generate surveillance data, we'll be able to use that data, applying epidemiological methods to review these thresholds for Lassa fever in Nigeria. Move on. So I mentioned that we could approach the surveillance routinely or in an enhanced manner. And this is just a general suggestion of the approach to enhanced surveillance as against routine. And this is usually applied during outbreaks. A few things to consider is that during an enhanced surveillance mode, when you have confirmed an outbreak, the community must be mobilized to identify more cases. There must be community-based surveillance. There must be community awareness campaigns. Healthcare workers in the areas need to be sensitized afresh, and everybody should support active case search, active case finding. Any suspected case must be immediately reported, presently through paper and electronic modes. Of course, we expect that the LGA DSNOs can report on summers, and hopefully very soon some facilities will also be doing that. And then case investigation must be done on every suspected case. In many cases, appropriate samples collected and shipped to the relevant laboratories for testing. All this is part of surveillance. Furthermore, contacts must be identified. If you identify a case, a confirmed case, you list the contacts, the close contacts, you may categorize the contacts and follow them up for 21 days from the date of exposure, again, applying the incubation period to surveillance. And of course, in all this, you must apply IPC measures to protect yourselves as surveillance officers, as well as to prevent a confirmed case from spreading it to others. So they will need to be isolated while surveillance goes on. Of course, the EOC activated for the response will need to review the data frequently. Review the data coming in through surveillance frequently. Depending on the magnitude of the outbreak, it could be as frequent as twice a day. It could be as automated as continuous. It could be as frequent as once a week, depending on the magnitude of the outbreak and the facilities available. Furthermore, and very importantly, during outbreaks, the index of suspicion should be heightened to strengthen acute febrile illness surveillance. So there's a lot of collaboration in an enhanced surveillance mode applied during outbreaks. Move on. So to try to wrap up this presentation, I would like to say that I would like to make some general recommendations, especially to states, to have a well-staffed and equipped epidemiology division for IDSR implementation, as well as EOC operations. It's very important that states have a well-equipped public health emergency operations center, an event-based management system to collate and analyze and respond to data, to events that may be happening in the communities as much as possible. Secondly, we need to really institutionalize the One Health approach, not only to response activities, but right from surveillance. We need a One Health approach, institutionalized and functioning at the subnationals. We need to routinely carry out all the other requirements we talked about for Lassa fever control. The surveillance, the routine surveillance, enhanced surveillance, the after action reviews, and so on and so forth. All those should routinely be carried out to ensure Lassa fever control. So having said this, I hope that we've been able to see. One other thing I would like to mention is that all surveillance officers must be familiar with the tools for collecting data. They must be familiar with the tools. They must be reasonably familiar with how to analyze the data to inform actions. So for now, we still use the paper-based tools, the case investigation form, the contact tracing forms, but we have largely deployed the electronic IDSR in form of the SOMAS software for data collection and analysis. So with this, surveillance has improved, but we know that there is still a lot of milestones to cover, especially at community and facility levels. Thank you all for listening. Perhaps we can take questions.
All right, thank you so much, Dr. Abaye. So the questions will actually be dropped in the Q&A chat box. And then at the end of all the presentations, we'll just, there's a session for question and answers, and then the one directly posed that you'll be read out. But for now, there is no question in the chat box so far. So please, colleagues, drop your questions in the Q&A chat box. Okay, so this takes us back to our earlier presentation by Dr. Banji from the US CDC, who will be making a presentation on the overview of Lassa fever in Nigeria over the years. Over to you, Dr. Banji.
All right, thank you. Thank you, everyone, and good morning. I hope you can hear me now.
Yeah, yes.
Good, thank you. And all protocols observed. Thanks, Dr. Abaye, for that opening presentation. I think you've done some good justice to what I will be discussing today. So I'm here to just talk briefly about Lassa fever and then walk you through our experience with Lassa fever, especially in this year, 2023, and then some of the bits and pieces we've done at the national level. So I will start by just, we all know that Lassa fever is an acute viral illness, a viral hemorrhagic fever, actually, which means this is one of the characteristic symptom of Lassa fever. At the later stage, you begin to see blood from the orifice. And we always say, don't wait to that point before you start treatment, because we've seen that it is much associated with mortality. So the first reported case of Lassa fever was in Lassa village in Borno State in 1969. I think this has been well established. And since then, I think the next case, even in Borno State, was 2017. We will not say that surveillance have been very optimal between 1969 and 2017, but what we have seen from 2017 till date is there are lots of cases in Borno State as well, but now spread to the whole other states. And then even Borno, where the Lassa fever originated, is not one of the high burden states as at 2023. And so we know it's a single-stranded RNA virus, and also it's a zoonotic disease, that is a disease you get from animals. Next slide. And this animal is our very famous rodent, the Mastomys natalensis. It's a multi-mammate rat. So you see, we've seen several pictures of the rats in some of our surveillance activities in communities. And so we know that transmission is mainly rodent to human through contact with urine or feces or secretion from the infected rodent, or injection of food contaminated with this same particles. And this is what we have seen in probably states like Ondo State, where a lot of food processing, similarly Edo States, which we think Lassa fever infection is more likely to be associated with local food processing as well as food storage. It could also be human to human and through contact with blood and bodily fluid. This is one of the concepts that is guiding the response to Lassa fever in Nigeria. When a case is confirmed, we conduct contact tracing. For this, we list all persons that have contact with the suspected or confirmed case. But we've also known that for human-to-human transmission is mostly, we've observed that more in healthcare settings where you have clinicians and health providers coming down with Lassa fever because they are treating a Lassa fever case. And I think a lot of interventions are already going into prevention of human-to-human transmission, especially healthcare workers in the course of treatment. And we've seen a lot of improvement over time also in this area, where you have a facility, for instance, with 10 confirmed cases and none of them died. So we've seen improvement in management of healthcare workers. The idea is to detect early, and that's why contact tracing continues to become very relevant in management of Lassa fever. Next slide. And so, again, we've established this trend of Lassa fever over the years, especially from 2017 to date, where we think surveillance really has improved, and we now have a fair understanding of our Lassa fever outbreak in Nigeria. And if you look at what we have recorded this year from January 2 to November 12, we've recorded 1,127 confirmed cases, of which 192 died. And these were recorded from 114 LGA, local government areas in 27 states and FCT. But last year, as at November 12, 2022, what we had reported was 985. So you could see that we had more cases and deaths in 2023 compared to 2022. And if we go also down memory lane to previous years, you will see similar trend. And so we know that 75% of all confirmed cases are reported from just 3 states. So we can see that Ondo, Edo, and Bauchi State are accounting for 75% of all confirmed Lassa fever cases in Nigeria. And this is important because before, probably between as of 2018, 2019, you see that Edo is the most affected. That has changed to Ondo State. Also, you don't find Bauchi there, you find Ebonyi. Ebonyi was one of the first 3 most affected states. Now Ebonyi has dropped, just probably after Bauchi. So we now see that though Edo and Ondo continue to stay on the list, you see that Ondo is now the most affected state, or accounting for most cases, which is 35%. And our case fatality proportion this year, that is proportion of cases that died, is 17%. And you could compare that to last year, which was 18.5. This is still a far cry from the single-digit case fatality that is underpinning our strategic plan. So again, but to tell you that we've seen some reduction in mortality, and we've seen some improvement in treatment outcome as well. So again, as at this last week, last week, we have already established new cases from Ondo, Bauchi, Taraba, and Edo states. And this was signaling to us that we are already approaching or in the high transmission period. Next slide. And so this is the map of Nigeria showing the distribution of, just showing confirmed cases from week 1 to week 45. And you could see where we have green, the states that have reported positive cases. It's good to mention that all states have reported at least one suspected case, whereas we have is it 26 states that have reported at least one confirmed case, an FCT. So you see those yellow or gold color as states with suspected cases. Please go back. Thank you. And then in trying to look at the of the balloon, which tells you what state is reporting what magnitude of cases. The smaller one is just states with 1 to 53 cases, and then the next one is 54 to 127. And where our priority area are the states that have reported 128 to more than 128 cases. That's Ondo, Edo, and Bauchi states. Ondo and Edo state actually. So Bauchi, Taraba, Ebonyi, you see them between 54 and 127 cases. But this also let us know where to prioritize our response, because we know that large number of cases will come from a few states, which we'll see in subsequent slides. Please go ahead. And yes, I think Dr. Bayas reported a bit of this, but this is just showing us the epidemiological curve from week 1 to week 43 here. But again, it's just to tell you that most of the cases occur from between week 1 and probably week 15. And that is where we have identified as our high transmission period, and we are already about getting into that. If we have started this epi curve from probably December, so probably epi week 50 or epi week 48 of last year, you will see how the case were increasing. And that is where we know that we have started a new season, and all action will now need to be targeted towards response. Next slide. And that chart also shows that we report case every week of the year. So there is at least one confirmed case every week of the year. And I think even we can take it as a minimum of probably 3 to 4 confirmed cases every week. Now, if you look at this, it tells us the state, how the state are contributing to the Lassa fever burden in Nigeria. As reported earlier, Ondo State is the most affected, but you see now we've added Taraba and Ebonyi. So the 5 states are accounting for 89% of the total confirmed cases. So if we target these 5 states, we are likely to resolve most challenging part of the Lassa fever outbreak in Nigeria. And we also were able to break this down to local governments. So you look at 10 local governments in Nigeria. Out of the 114, 10 local governments are accounting for about 67% of all cases. So you see, probably if we had 1 or 2 local governments to this, we'll be saying probably 12 local governments are accounting for about 70% of all cases of Lassa fever. And then it means we know where the cases are coming from. And this is consistent year in, year out. I wish we would have projected and showed you situation in previous years, but this is consistent. We know these local governments, we can quantify the number of cases that will come from them, and so targeting response to these local governments should be a top priority. And the states also that this local government fall into, we continue to engage with them to let them know that if we can work, if we can target our interventions with minimal resources that is always available, limited resources, we can really, really bring down the burden of Lassa fever. Next slide. And again, this is just telling you the trend and to tell you that we have data from 2017, but this is showing you a 5-year trend from 2019 to 2023. And if you look at the shape, you see that the trajectory is the same. It rises up from week 1 and starts declining about week 15, and then you see a similar trend all through the rest of the year. But this is telling us that we know within what period Lassa fever will be we will have high transmission of Lassa fever in country. Next slide. And again, in trying to understand, because if you look at what Dr. Abayi has presented to us earlier, a single confirmed case of Lassa fever is an outbreak. Now, because we report Lassa fever every week of the year, and we are already thinking, we've established that Lassa fever is endemic in Nigeria, we now decided that it's important to have an emergency threshold. That is, what number of cases will constitute an emergency that would trigger emergency response. And we also look at, beyond just the case count, are there other factors that we need to consider to arrive at the fact that a country, Nigeria, or a state in Nigeria like Ondo State is in Lassa fever emergency? So again, we have a lot of factors to consider here. We have the case threshold, which is the number of cases, and then we have bed capacity. Most of the time we realize during an emergency, bed capacities are always exceeded, and that always calls for some serious challenges for case management. So we said if we have two states exceeding bed capacity, we know that this is triggering an emergency. Also, the case fatality proportion, if we are reporting anything more than 25% per week, we know we're in an emergency. If we have 2 healthcare worker infection per week, it will tell you that it's going to affect case management in the facility. So if healthcare workers are coming down with Lassa fever and we have that considered 2 per week, then we know that this could signal a potential emergency. Another factor we consider is sample turnaround time. We want to be able to test our sample within 48 hours. So if we have 20% of samples with collection to result that is exiting 48 hours turnaround time, then we believe this is also telling us our system for sample management needs some investigation and improvement. Of course, safe burial also. Safe burial is one way to also transmit Lassa fever, unsafe burial rather. So if we have 2 unsafe burials in a single week, then we think we may be having a much larger outbreak on our hands. And the last one here is adequate suspicion. It's not just enough to say we have surveillance. Are we detecting enough suspected cases based on historical data? So all these you see here are what are driven by the data we've collected in the last 5 years. So we've been able to establish some of these factors as very important to consider to declare a Lassa fever emergency. And we believe when you compute this, please go to the next slide. So if you look at what has happened over the last, this year, from Epi Week 1 to Epi Week 45, when you add all those indicators together and you come up with a percentage, now this is what you get. This is the trend of the emergency indicator since January to date. So you have from week 1 to week 45, you could see 70% here is the emergency threshold. Once you cross 70%, we are in emergency. Between 15 and 70 is the outbreak. And that also has its own activities. But we've identified specific activities that need to happen when we cross 70%. And you could see that we've crossed 70% right from week 2, then back to week, probably week 7, we went down, we came up again. So we have decided that for us to even declare containment of emergency, we need to be below 50%. The moment we cross an emergency, we need to be below 50% for 3 consecutive weeks. And these are some of the ways we've been able to determine how, when we are in an emergency for Lassa fever in Nigeria, and when we have contained the emergency, and we can now go to the alert phase. Next slide. And this is the typical example of the dashboard that we use. This is the computer emergency indicator dashboard. You could see as at week 45 now, we are already in 80.1%, which means we've crossed the threshold. And if you look at what happened this week, that week, you will find mortality was high. You will find healthcare worker infection was also observed. And this will trigger some concern. So mortality was 33%. The case threshold was high, already more than what we anticipated. The bed capacity was not exceeded though, but you could see that the suspicion was also not enough. We're supposed to have suspected 154 cases, but the suspicion was just 95. So it tells you that there's things that we need to do because we're already approaching or we're in an emergency phase. So again, these are some of the things we've used to classify Lassa fever outbreak, to know when to trigger a national emergency and when to trigger emergency at the state level, because we also have this computed at the state level. This is the national one. And then to know when after a period of response, when we have contained the emergency. So just to let you know that these are some of the works we've been doing at the national, and also that has been cascaded to the state. And as we are approaching the new transmission, high transmission period, all this will begin to show up in many of our reports, and also data will be used to guide the response. And as Dr. Baye said, when we detect early, we can respond early and contain the spread early, which is very important. And that aligns with our 717 outbreak response timeliness metrics. And these are some of the things we do to ensure we are on top of Lassa fever response in country. But again, we'll continue to emphasize that ownership at state level, ownership at subnational level is what can drive the response. And if states can focus on those local government that we have identified with support of partners and with support of the national, I think we'll be able to drive down the burden of Lassa fever in Nigeria. I think this should be this last slide. Next slide. So thank you for your attention.
Thank you so much, Dr. Banji, for that wonderful presentation. And colleagues, this is still a gentle reminder for us to drop our questions in the Q&A chat box. I haven't seen any questions at all. I hope we have not totally lost you, or does that mean we are doing a very great job and there's no need to ask any questions? But it would be helpful if we can just to clarify any thoughts. Okay. So this takes us to our next presentation, and this will be on case identification and contact tracing with active case search. Mrs. Favor Makava Deniji will be presenting it, making this presentation, sorry. And she's a technical advisor, surveillance and data management with JPIGO. Colleagues, please help me welcome Mrs. Favor for her presentation. Over to you, Favor. Thank you.
Thank you. Good morning, everyone. Please confirm that you can hear me.
Yes, we can hear you loud and clear. All right, go on.
All right. Thank you, DG NCDC, ably represented, the Director of Surveillance, the TWG, and every other protocol duly observed. As we are aware, surveillance is in two types. We have the active and the passive. And for this section that we'll be going into in the next few moments, we'll be looking at case investigation, contact tracing, and active case search. All of these three components falls into the two types of surveillance, which is active and passive. Case investigation. This is an epidemiological investigation that is conducted for all signals. Signals here could be, as some persons would call it, rumor or suspected, and as well as confirmed cases or death that are attributed to Lassa fever. And just to mention that case investigation is a surveillance activity, and for surveillance, it is not an individual task. Hence, we would encourage the One Health approach. So you have a couple of individuals who will be doing this activity. And for us to effectively carry out a case investigation, we need to utilize the surveillance reporting tools. So we have the hard copy case investigation form, and as well as the SOMAS platform. The LJDSN, as earlier stated by the first speaker, Dr. Abaye, is expected to enter all cases that has been filled into the hard copy CIF to the SOMAS platform. And they're also encouraged to fill the contact sections of the CIF. So this is a very important component of the Lassa fever surveillance response. With a thorough case investigation, we're able to break the transmission of Lassa fever, and as well as being able to go by the narrative of having a single-digit national case fatality target, because if cases are identified early and are taken to the treatment center, the chances of the case being alive is really, really high. Next slide, please. For case investigation, we have several components to look at. The first is the patient information. This entails the biodata of the patient, because it is really, really critical for case investigation. We need to know the name of the patient. Following that, a unique identification number is generated by the LGDSN of the state to the patient or the suspect, as the case may be. So you also have, following the epidemiological number, we have the home address, and would encourage that home address should be explicit enough. So the surveillance officers, in this case, the LGDSNOs and other ministries, once they go for investigation, they are able to visit the home of the confirmed or the suspect case to have the investigation properly done. The next is the travel movement. This is also going to help to break transmission. We should be able to know where the case is coming from and the places that the case must have visited upon being sick or at the early stage of the suspect or the confirmed case. The next is the risk factor. The risk factor here is sort of looking at the conditions of behavior a case must have been exposed to, and there is that likelihood of the case developing any of the signs and symptoms or classical symptoms of Lassa fever. And you're also looking at the epidemiological link. That's a case association with individual or a case in an outbreak. This is also based on epidemiological evidence. We're looking at the linkages, and those would also help public health professionals, that's those at the health facilities and the workers at the community level, to understand the transmission dynamics of the disease, and it will help to trace or track the source of infection or common exposure that the case or suspect would have had. Data documentation, this is highly significant. The slide, the presentation that was taken by Dr. Banji is as a result of good data documentation. That's why we're able to bring all of those data. We're able to identify the hotspot states, as well as narrowing it down to not just the LGA, but the communities where we're constantly reporting confirmed cases of Lassa fever. And we're also able to do a 5-year trend of this Lassa fever. So documentation is really, really critical. And how do we get all of this data? Is from the information that has been transmitted into the hard copy CIF, that's a case investigation form, and as well as those that has been uploaded into the CIF, which is the SOMAS. Again, another thing that we've also observed that that should be corrected is on the contact information aspect on SOMAS. All LGDSNs who are the users of SOMAS, I kindly encourage to fill that section while entering the case information on SOMAS. Next slide, please. Before we go into contact tracing, maybe we'll start by defining who a contact is. Essentially, a contact is someone who must have had an exposure with a confirmed case of Lassa fever or a death that is associated with Lassa fever. And for contact tracing, there are 3 major aspects. First is the contact identification. Following an investigation in a home where, in a household where a case has been confirmed for Lassa fever, we now need to identify all of those individuals. And next is to list them or list them using the contact tracing form. And the next is the follow-up. For Lassa fever, the follow-up period is within 21 days. And this is expected to be a physical visit and not a full conversation. Yes, we might want to explore the phone conversation of getting detailed information about a contact, but that is highly discouraged, as you might not be getting the accurate information that would be needed. So it's advisable that we visit the home of a confirmed case to get all of the contact information filled. Next slide. This diagram here just tells us that if we're able to identify Mr. A, so Mr. A for me is the very first diagram. We are also able to, identify individuals who must have had contact with Mr. A. And from a contact of a contact can as well generate further contacts based on their level of exposure. If we are able to isolate, that's by taking Mr. A to the treatment center, because obviously Mrs. A has had close contact exposure with a confirmed case or a Lassa fever death. So it's advisable that Mr. A is taken to the treatment center where he would be managed. we're able to save every other contact. And this would also prevent other persons in the community or at the health facility from getting sick. And this will be done using all of those tools. Dr. Abaye in his section also emphasized on the need for all LJDSNOs and healthcare workers to utilize all of the surveillance reporting forms. So in the next slide, we'll be looking at how a contact can be managed. One is the tool for contact tracing. So for contact tracing, there are certain forms excluded from the case investigation form. So we have the contact listing form. In here, the information that contains includes the name, the address, the temperature of the contact, on a daily basis, the date. For a period of 21 days, this contact, as soon as they are listed, they are being followed up to see if they would exhibit any of the symptoms that is suggestive of Lassa fever. And following the listing of the contact, the next is to now do a contact categorization. And once that categorization is done, we now need to follow this set of individuals for the period of 21 days. Next slide. Now we're looking at the categorization of contact. There are three major categories. The first category are the low-risk contact. These are casual contacts, as the case may be. These are people who would have shared a room with at the early stage of a patient, or people who would have handled laboratory specimen under a contained conditions. The second categories are the low-risk contact. Yes, they would have had direct contact with a patient, or with a patient, or they would have breached some level of laboratory containment measures. These contacts are also required to be followed up, but the ones that need that close follow-up for physical visits are the third categories, which are known as the high-risk contact. These are contacts who did not protect themselves and would have had exposure of skin or the mucous membrane through a potential infectious blood or body fluid of a confirmed case or death of Lassa fever. They include unprotected handling of clinical laboratory specimen, and then the mucosa exposure of splashes, and of course needle pricks. And this can also, their level of exposure or the rate at which they've been exposed to the contact could be as a result of sexual intercourse or contact. Next slide. So for the contact monitoring, this is a daily activity. So we're recording the biodata of the patient. We want to also be able to document the temperature of the contact. So we're not just putting high fever. We should be able to assign a number to it. If a contact should have a fever, it's already a red flag, knowing that Lassa fever is one of the associated febrile illnesses. So once the temperature is above or within 37 and above, it's already a red flag. And then any other symptoms that may, of course, once this happens, next is to now look at the categories and see where such contacts falls into. Next slide, please. Active case search. This falls under the passive surveillance. However, knowing that Nigeria is endemic for Lassa fever and we have our hotspots, states and communities identified, it is expected that during and after an outbreak, active case search should be done at the community level and at the health facility as well. This helps to identify suspected Lassa fever cases on time, and this also would help to break the chain of the transmission. And for active case search, this should be initiated within 48 hours after a Lassa fever case has been confirmed in a location, be it at the community or at the health facility. At the health facility level, it's a retrospective data review. So you're going into different patients' case notes, identify patients. A typical example would be in a hospital or in a community where you're having constant reports of people who have been treated for malaria, yet the symptoms is still there, they're not responding to treatment, that's a flag already. This contact needs to be investigated properly. Next slide. So for active case search, we need to, like I earlier said, if this is conducted at the health facility level, we're reviewing all healthcare records. And then for the informants, community informants who will be working at the community level, good thing is that I'm happy to know that we have DSNOs and state epidemiologists, and as well as some clinicians from the health facility. We need to begin to look at our registers, and then in communities, following the just the previous slides, we have been able to identify communities now from the high burden states where we're having confirmed cases of Lassa fever. So we need to intensify active case search at the community level and as well as the health facility. We need to begin to sensitize our clinicians. We need to begin to sensitize our community informants so they are aware. We're already in the next outbreak phase following the data that was shared earlier. And then we also need to offer intensive care. We are encouraged to fill the contact monitoring forms. Also, we're doing this for the states who are already having confirmed cases. And this should be well filled so that our data are accurate and the data is also able to inform targeted public health interventions. Next slide, please. So in summary, a thorough and systematic case investigation, contact tracing, and active case search would help everyone, now ranging from the national to the state and as well as the LJ level, to understand the dynamics of the Lassa fever transmission. At the moment, we know that the transmission from evidence-based data is rodent to man, and then have the health facility human to human transmission, but that is also not enough. We should be able to do our contact tracing and active case search so as to break the transmission. And also, once all of these three components of surveillance are carried out the right way, we're able to implement a targeted control measures. Here, we'll be using the One Health approach. This won't, I think emphasis also has been laid on this by the previous speakers, and also will prevent further spread of the virus both in the community and at the health facility level. All of these components contribute to a comprehensive understanding of each and can help public health responses. Thank you. We'll be happy to take questions during the Q&A section.
All right, thank you so much. I'm happy you said that because you have a lot of questions with regards to your presentation. So it looks like you opened the floodgates for questions. So I'm happy you're ready for that. So thank you so much for that beautiful presentation. This will take us to the very last presentation we have for the Q&A. And our very own Michael Amodu Onoja, Senior Program and System Analyst at the NCDC, will be taking us on data management and reporting tools. Just like we've said before, please keep dropping your questions in the chat box. And also the attendance link will be reshared again. Thank you so much. And over to you, Michael.
Thank you. Thank you very much, I am. Good morning, senior colleagues and other colleagues and fellow disease detectives on the call. I will just walk us through the data management process and the reporting within the Lassa fever TWG and also as it happens in NCDC. For NCDC or as a country, during the last review of the third edition of the IDSR technical guidelines, it was agreed during that workshop that SOMAS will now be the key data collection, analysis, and reporting tools, the digital platform of the IDSR for the country. So SOMAS is an acronym for Surveillance Outbreak Response Management and Analysis System. So because we know currently we've deployed SOMAS to all 36 states and the FCT, we've deployed SOMAS at the LGA level, and Lassa have always been the disease TWG that have pushed SOMAS growth over time drastically. This is to say that for Lassa fever, there are other modules on SOMAS for case management, for contact tracing, the whole contact tracing process, and everything that happens within outbreak investigation and response of Lassa fever outbreak in Nigeria. So for key Lassa fever tools that we use, I've mentioned SOMAS, which is a combination of all of these tools currently. But because we have not deployed to all facilities in the country, we are only deployed in priority treatment centers for Lassa fever. We are still running concurrent structure. We are reporting on a digital tool, and we are also using paper-based. Till we are sure we've deployed SOMAS in all the facilities, then we can abandon the paper-based and move to the digital systems. So these are other tools we use during investigation and response to Lassa fever outbreak: the case investigation form, the case management form, the contact tracing and monitoring form, the temperature chart, and of course, everything that happens within the Lassa fever testing in the country. Please, let's go to the next slide. So I brought out the definition of public health surveillance, not to reemphasize what Dr. Abayi and other speakers have defined public health surveillance before, but just to emphasize that all we do around the public health surveillance is all to achieve high quality data to be able to guide all of our decisions within the investigation and response for Lassa fever. So if we have quality data within the public health surveillance system, it can help us achieve all of those key items there: evaluate program impact, determine appropriate public health interventions, monitor the progress of the programs, determine the population to target for intervention, determine barriers to care, and influence public policy. Within this data collection or data management process, there are some key steps that happen within all of this process. There's the collection bit, the processing bit, looking at the quality of the data, the analysis, and of course, storage, putting in mind confidentiality and privacy. Let's move to the next slide. So I will not drag you too much on this, but this is just to show you how the case investigation form looks, because I saw a question that was asking, if we identify a case at the facility, how do we go about it? So this is the form we used. And of course, if a case is identified at the facility following the IDSR structure, the next step would be to report to the LGA DSNO to conduct investigation and to do all of the other investigative process. So the case investigation form, you can see these first two sections. The first section talks about the reporting facility, and the second section talks about the residential address of the case. When we come to data quality, I would emphasize on these two bits a little. Let's go ahead. So the third section captures the patient's information, all the biodata of the patient, the occupation, and all other information. Next slide. This is also a continuation of that section. This section captures, did the case arrive alive or dead? What treatment facility are we managing the cases? If the cases died on arrival, did we conduct safe burial, or how was the body handled? You could see that this is one indicator that we also have in the composite indicators we use to monitor the threshold. And section 4 talks about the symptoms. These are all symptoms that research or literature over time has showed could be associated with Lassa fever. And the other part, the next slide, will talk about continuation of the symptoms and mostly bleeding, which is one key indicator to look at for Lassa fever. Section 5 try to investigate what might likely be the source of infection for this case. Could it be exposure, known or unknown, to a confirmed case of Lassa fever? Could it be exposure to anybody at all within that geography that could be showing symptoms of maybe all of the AFIs? And then we can triangulate to know if it's Lassa fever. So this section try to investigate source of exposure. The next page will show you a continuation of this section, which try to investigate contact with rodent. Literature have already proven that it is not the consumption of the rodent actually that is the major risk factor. The major risk factor is around the hunting, the preparation, and all other interactions we have with either the rodent or the excretion of the rodent. Let's move to the next slide. So section 6 talks about sample collection, the date it was collected, the date it was sent, and all of those. You could see how all of these data points link into our composite indicators. This is from where we could track TAT and all of those issues around laboratory. Let's go ahead. Section 7 talks about the outcome of the case and the discharge details. So now that we've seen the case investigation form, the next thing we would want to ask is who is responsible for filling this form? This form can be filled by anyone trained enough to conduct investigation for Lassa fever or generally VHFs. It could be personnel in the community who have this training. It could be personnel in the healthcare facilities, and mostly our designated Lassa fever treatment centers across the country. Investigation is key to whatever we do around investigation and response to Lassa fever outbreak. Because if we do investigation properly, then we can properly document cases in the surveillance system. You saw where we could show a trend of 5 years, 6 years reported cases of Lassa fever. This will actually guide policy and response activity to subsequent Lassa outbreaks. So investigation is very important for this process. Understanding potential sources, as we discussed through the sections of the case investigation, you see there are sections that try to investigate source of infection. If we have this data properly captured, then of course we could make decisions and have more understanding around what might be driving outbreaks of Lassa in the country, and also generate contact line lists. We have this common investigation in surveillance to say, if you don't conduct investigation, there is no way you can have a contact list. If you don't have a contact list, there is no way you can follow contacts to know what is happening around contacts, either in the community or in the facility. And if we don't do proper contact tracing, we always have big outbreaks to battle with. So case investigation and contact tracing is very key in the control of Lassa outbreak in the country. So now let's look at around quality of the data we've been dealing with. If the data is not of good quality, then all the efforts and resources we'll be putting into investigation and response to Lassa fever might come to nothing. So data quality cannot be overemphasized. There are key items that we use to characterize data quality in the system. One of them is accuracy. Accuracy looks at the correctness of the data that has been captured. I would give you an example. Last year or 2 years ago, we decided to investigate Lassa fever in pregnant women. How does this disease behave around pregnant women? But when we try to use the data, there were a lot of discrepancies. You will see a pregnant male. Sometimes you see a pregnant female that is less than 12 years. So correct accuracy of data has been a major issue we battle with in the surveillance system. And thank God we have opportunities like this where we could sensitize all stakeholders across the structure to see how we could do to improve this process. Another item is the completeness. Completeness of data has been really a major issue. The best practice for data analysis is to say, delete all respondents with missing data, so as to improve the power of your findings. But in this case, in the surveillance system, if you try to delete respondents with missing data, you find that you narrow the sample size, and that also compromises the power of the output. So it's been a major issue, but we thank God for situations like this where we could keep sensitizing and encouraging ourselves to improve the data quality across accuracy, completeness. Let's move to the next slide and see other items. Reliability is another key item. How reliable is the information? Like I mentioned earlier, we are using SOMAS to capture all that happens within case management,
the case investigation process, the source of infection, and all of those. Sometimes you might want to triangulate what comes from the lab and also what is on SOMAS, because SOMAS has more complete, more variables to deal with. But you find out that for some states, the line list is reporting 30 cases, SOMAS is reporting 15 cases. Or the information for a case with a specific unique EPID number on SOMAS and also has unique EPID number for the line list. But certain variables are different. One is male on this platform, one is male on the other platform. So we keep encouraging stakeholders to please, while we do our work, we know it's an emergency, data quality is key. And timeliness, of course. If we miss out on timeliness, people might die. So we're using this opportunity to encourage stakeholders to look at these elements of data quality, and let's see how we can improve the system so that our decision making are really fine-tuned with quality data, and interventions can be channeled to where proper interventions can be used. You see the section of the case investigation form that is reporting the facility that we manage the case and the residential address of the case. We notice in some states, for instance, we're responding to outbreak in Ondo State. We see a lot of cases as if OWL is reporting large number of cases. But one would dig deeper. We just notice that people come from other LGA. For whatever reasons, they just feel, yes, I stay in OWL. But they really don't stay in OWL. It might be from other LGA. And if you focus intervention in that LGA, we'll notice the outbreak is not going down. But that's because data has misled us to focus intervention somewhere else. So please, colleagues, data quality cannot be overemphasized. We'll keep pushing till we have quality data in the system to make decisions. Let's move to the next slide, please. So currently, we have 8 different labs all over the country that does testing for Lassa fever. And whether at peacetime or at wartime, these laboratories share their information at least twice in a week to guide decision making. As we notice already, Lassa is like all year reporting. So we must keep doing one activity or the other throughout the year. So all of these labs share information twice in a week. Let's go to the next slide, please. So speaking about SOMAS, that is now the approved digital platform for priority diseases in Nigeria. SOMAS as a tool, the whole idea is digitizing the IDSR system. There is nothing new. It's not a new system. No, it is the IDSR that we know that have been digitized. Currently, we are running on 2 platforms. There is a mobile application and there is also the web application. Each has their own advantage and disadvantage, of course. For the advantage for the mobile platform, the good thing is if the investigator or maybe the contact tracer or the case investigation team can use the platform to capture data real time. But the issue is you might all stakeholders along the structure might not see the data at that time. So you can capture data offline, and when there is network, you can synchronize the data into the system. This is mostly used during outbreak or hard to reach area where network coverage might be low. But of course, one of the challenges is the synchronization time, which we've been battling with for some time. And as NCDC, we are actually working on that. Soon enough, we'll settle that synchronization issue. But then that was why we have the option for the web-based. The web-based run real time. But then the only challenge is, does everywhere have the same network coverage? So we can use both systems to capture data. It has a lot of modules, like I said, covering surveillance, covering case management, covering contact tracing process, covering event-based surveillance, and covering case management, everything that happens between the management of all Lassa fever cases, and also what happens around the testing. Let's move to the next slide. So this tool, SOMAS, actually would help us actualize these major items: timely and unambiguous surveillance. We can conduct outbreak management on the platform because every player in the surveillance system are directly on the platform, and we can see information fly real time. State officers can send out tasks to LGA officers real time. The LGA officers can see the information real time, act on it. At the national level, everybody can see what is happening in the structure real time. There's also the place for analysis and reporting functionalities. Of course, it's a reporting tool, and there is one bit that does analysis. So on the platform for SOMAS, you can analyze data and generate output directly. And it is user-centered design, meaning it is designed with knowledge and experience from everybody in the surveillance structure. So it is not somebody designed a tool and give us to use. No, we all sat together and designed this tool. Next slide, please. So if we properly implement SOMAS, all stakeholders across board, across all levels, we can achieve key things as the following: standardization of data, improve timeliness and completeness. Like I say, SOMAS work real time and all stakeholders can see the data real time. Although there are challenges with network, of course, it's a countrywide issue. But then if network is strong, everybody is on the platform and can see what is happening across the board at the same time. Early detection is possible. Early detection, investigation, and response to outbreak is possible on SOMAS because as soon as you report a suspected case on SOMAS, every player on the structure sees the information almost immediately, and we can begin to take action immediately. It has reduced to a large extent manual data entry that we have battled with for some while. And of course, we know manual data entry, out of exhaustion or whatever reason, errors begin to come in. So SOMAS will help us to achieve all of this issue to some extent. Let's move to the next slide and see what we can achieve with SOMAS. Rapid transmission of data. As you load up the data, everybody in the structure can see. Better management of data through provision of international security and storage. The data on SOMAS is confidential. Not even every user of SOMAS can have access to all the data on SOMAS. There are privileges, depends on your login access. There are certain information you cannot access. So data security is guaranteed with SOMAS. Of course, I mentioned the visualization analysis that SOMAS can do. You can analyze on SOMAS and export data out. And of course, improve quality of data. Because if there's an error on the information you have captured earlier, with SOMAS, you could just log in and update the information. So SOMAS will help us achieve all of this. So let's see some comparison. Next slide, please. Let's try to compare paper-based and digital system. We know that paper-based is a quite simple technology. Biro and paper, you are filling the form already. But then there is always information delay. You fill the information at a remote health facility before it gets to the DSNO sends it to the state sends to the national. All of those time, we are dealing with infectious diseases. The cases are spreading, and of course, the deaths. Updates and correction difficult. You have sent a form. You now notice, oh, I reported 6 cases instead of 9 cases. Updating the form, difficult. You can't get back to that. Cost of manual entry, of course, cost of transportation, and some other challenge we see with the paper-based. But now that we are using the digital system, SOMAS, and this is the more reason why I want to encourage all stakeholders to continue to use the SOMAS platform. Let there be conscious move to migrate from paper-based to the digital system, because there are a lot of good we would achieve from that. Real-time information exchange is possible if we use the digital system. Easy updates and correction, like I mentioned. You enter the case that the case is 12 years, but you notice, oh no, it's a 22-year-old person. You can go on SOMAS platform almost immediately, open that case, go to the age, and update to 22. As soon as you update and save, everybody on the system knows, oh, that information has changed. There is no manual data entry, because that process of transcribing from paper-based onto the digital system, error can come in. But with SOMAS, you just fill in on the platform directly. No transport of forms needed, of course. Adaptation of forms is easy. I remember when we were designing the case management bit of the Lassa Viva TWG, anytime the case management pillar thinks, oh, we need to adjust the form this way, it is just a matter of speak with the SOMAS team, and in few days, we have that adjustment done. But imagine if it were a paper-based. It means we have to hold a workshop, all stakeholders have to agree, we'll go for adoption and all of those. But adapting forms on SOMAS is quite easy. Immediate automated analysis possible. But then there is one challenge. It requires electricity and connectivity. We'll try our best to see how we could solve those by providing power banks to the devices that we have deployed, and also try to support the officers with internet data so as to continue to use the system. But we know it is never enough, but we'll keep pushing, of course, to get to that perfect system. So please, at this point, you could click more than 3 for going forward. This is just showing for all we do around epidemic or outbreak or epidemic response, it happens within the detection up to the control. And SOMAS have captured all of the users within this structure, be those at the detection, the facility, the community informant, the point of entry officers. They are all users on this platform. For validate and analyze, our laboratory, the surveillance officers who does contact tracing and other process are all captured on this platform. So SOMAS, I can say with all modesty, is a complete system for outbreak response management and analysis. It covers every bit of the process. What is just left for us now is to continue to use the system, and all stakeholders continue to share recommendations so that we can improve the system. Please click one more. So this shows how all players report data into the SOMAS platform concurrently. We don't have to wait for the DSNO to finish his work before the state can do the work and all of those. Everybody can work on the system concurrently. And there is a major challenge we found with the paper-based IDSR system, and that has been feedback. You send a sample from your facility, it takes more than a month or 2 weeks thereabout to get the result from the lab because of the back and forth process. But on SOMAS, feedback is shared also real time. As soon as the sample gets to the lab click on SOMAS that, yes, we have received the sample. The LGA DSNO doesn't need to call the lab to ask if you have received the sample. No, if it goes on the platform and open that case, it is clearly, you can see clearly that, yes, the lab has received this sample. And as soon as the lab conducts that analysis and impute the result on SOMAS, the DSNO or the health facility or the case manager managing the cases who needs the result to guide his administration and all of those, does not have to call the lab persons to say, oh, what's the result of that case? You just have to go on SOMAS, filter that case, and you'll see the result from the lab. If you click once, that will show us how feedback goes. The red arrow shows how information comes. Please click one more, and the green arrow shows how feedback goes back almost free time. So colleagues, because of time, this might not be the forum to discuss the intrigues of how you can use SOMAS, but I know hopefully we'll create more channels to have that discussion. Thank you very much for your time. This is over from me now.
All right, thank you so much, Michael, for that wonderful presentation. We're really happy to we're really happy to hear all this progress so far with disease reporting, and the role as well that Lassa fever has also helped to shape, and then how we can also better our response. So quite a number of questions as well for you. So I think we'll just start from there's a question for Dr. Banji. Dr. Banji, I hope you are still with us. So thank you so much, colleagues. Okay, so Dr. Banji, are you still with us? There's a question here for you. Is Dr. Banji still on the call? Or should I just move on? Okay, so I'm just going to assume. Okay, he's on the call, but I don't know if you can hear me. Okay, so let's move on to Favor. You have some questions here. So, okay, so I think there was a question with regards to if all states have surveillance focal persons, and I think someone already responded on behalf. Michael, we have both at state, LG, and healthcare facilities. So, and I think there's also a kind of clamor for sensitization in local government areas, because it looks like the surveillance focal persons are not well known. So if you could just comment on this. There are still other questions. Should I go on, Favor?
Maybe I just respond to the one on sensitization. So as we progress, thank you so much for that question. So you agree with me that in the country there is high attrition rates, and we've also observed that we have new state epidemiologists and LGA disease surveillance and notification officers. So we are not, before training can be made to those disease surveillance and notification officers, the national needs to be aware. And I'm sure, like I earlier stated, we already have data that is showing the hotspot communities. We can begin to start all of this sensitization. For states where we have new LGA DSNOs and new state epidemiologists, I think it's only wise that we request for a training through the as soon as possible. Maybe just also to mention that for active case search, we don't necessarily have to wait for states where we're receiving confirmed cases of Lassa fever in a bid to prepare and better respond to the Lassa fever outbreak. States who are yet to get a suspected or confirmed cases are advised to continue with enhanced sensitization and even risk communication and mobilization. So that is why we would always stress on the need for the One Health approach. There can be synergy between the surveillance team and the LGA health educators and all other stakeholders that are in the states. So yes, we can begin to intensify all of our sensitization and social mobilization activities. I hope I've been able to address that question.
Okay, yes, I think you have. So other questions, I think you have the most questions here. So do we have states, I don't know if this is related to what you said, but then if states have a pool of trained contact tracers who know how to use the contact tracing application on SOMAS. I'm just going to also take another question so you can answer both. Are persistent malaria cases also to be taken as suspected Lassa fever cases? So over to you for the last one for you.
So the question with regards to do we have states with pool of contact tracers, I would want to say yes, because for several interventions or outbreak response we've done for Lassa fever, we leverage on our community informants. A state that I know is one of our hotspot states, which is Ondo State. I know they have a structure well designed for contact tracers who have been trained. But then again, we know that for entering of cases into SOMAS, this is solely the responsibility of the LGDSNOs. So whatever information that has been filled using the hard copy CIF or contact tracing forms, ideally through the LGDSNO should be, who have been trained, should be transmitted into SOMAS. However, there is room for refresher trainings. And then looking at the attrition level, there is need also to conduct that level of refresher trainings or training of the LGDSNO so that they utilize that platform on the SOMAS, utilize the case contact model on the SOMAS platform. The other question is, will all persistent malaria cases be seen as Lassa fever? A red flag is in a community where you have consistent or outbreak of Lassa fever. We don't want to have missed cases. Apart from fever, I'm sure there would be other flags that would want to necessitate that suspect, because all of this we're doing now, all of this webinar is to improve the index of suspicion. That is why we now need to call on the DSNOs who have been trained. And I think there's a question, Dr. Yetunde, that has to do with the PPMVs, if they are aware of all of these Lassa fever surveillance and if they can do this. I know, yes, at the state level, most PPMVs, they also act as community informants, and these persons work closely with the LGDSNOs. So when they are picking persistent cases of malaria and is worrisome, there will be other symptoms too that is suggestive of Lassa fever, especially in a hotspots community. So yes, it needs to be reported, properly investigated, yes, and then reported. Thank you.
All right, thank you so much for that. You already answered the last question I was going to ask you. So I don't know if Dr. Banji is able to speak now because there's a question for you. Dr. Banji.
Yes, I'm here. I'm wondering if it's the first question on Edo and Ondo State.
Yes, please. That's the one. Good.
Try to answer in the chat box. But again, so just to reiterate that Edo and Ondo State are neighbors. We know that. And so we cannot rule out interstate human and rodent mobility. So again, we also know both states have some environmental sanitation as well as food processing issues. So overtaking each other is not something we can probably attribute to. It's still being studied, so to speak, but we have established there are some conditions that are more that makes Ondo State more susceptible to Lassa fever in the last few years. And those are what is underpinning or the response that have been proposed for this state. One of them is on environmental sanitation. Another one is on local food production. That some of the food processing practices could actually increase rodent-human interaction. And so maybe these are why we are having this. But if we have colleagues from Ondo State, they will also lend a voice to what they have seen so far in the states. So thank you.
All right, thank you so much, Dr. Banji. So Michael, I have a couple of questions for you. Michael, I hope you're still here.
Yes, I am.
Okay, so I'll just go right without any specific order. So there's one that's asking about interoperability of SOMAS with SITA-aware. So how is SOMAS data aligned with SITA-aware? That's one. There's also a question. I don't know how many you want me to read out.
Maybe
Okay, so
tools. You could do tools.
Okay, so I'll just go on. So how does SOMAS data align with SITA-aware? That's interoperability issues. Then, okay, this one is regards to ensure optimal performance of SOMAS, that it's essential to provide surveillance officers with necessary data subscription because SOMAS uses data and this will be needed even if they have their tablets. I mean, so those two, I'll still have another two or so for you. So over to you, Michael.
Right. Yeah, thank you. So for on SITA-aware and data and SOMAS interoperability, why SOMAS it's interoperable with any digital system. Currently, we have not linked SOMAS with SITA-aware. But as much as I know, I think SITA-aware is only capturing events. But if Dr. Yayada asked the question, think we should link SOMAS and SITA-aware, I think it is something we can take out of this meeting and just discuss in NCDC and have that process done.
Okay.
But for now, they are not linked. Internet data, since we deployed SOMAS, we've been supporting all users with internet data. If it is enough, that is another question. But we have been doing that, and we are also encouraging other partners and states to support surveillance officers the more in provision of this internet data. But I know we are making something available. It might not just be enough, but yes, we are doing something.
Okay. All right, thank you so much. So there's another one. So I don't know if you can answer or anybody with regards to routine active case search, especially due to COVID, a lot of cases, if negative for malaria, are usually suspected, or sometimes some cases are suspected for COVID. And so it's asking if persistent malaria cases should be added as suspected Lassa cases. So I think this one anyone can answer.
I think Favor answered this already.
Okay. Similar to what she answered, yes. Then
yeah, it's been addressed.
Okay, thank you. So then there's a question on how much of our local surveillance data and effort today is informing vaccine developments. Yes.
Okay, should I take that?
Yes,
I
please.
would have even preferred Dr. Banji to speak on that, but the CEPI team that is conducting the clinical trials for the vaccine,
I think they are integrated in the TWG workings, and we'll be sharing data to guide their processes. So I think with the vaccine team, there's been some collaborations, but I'll just allow Dr. Banji to speak a little more on this if there are other information you want to add.
Okay.
Thank you, Michael. Yes, thank you, Michael. I think you've said most of what I would have said. I'm probably allowed to say because the whole vaccination research that is ongoing is an offshoot of the research pillar, and there are regular feedback to the TWG at some point. I know probably the study is at its final stage now, and some potential another study on clinical trial that will probably commence sometime soon. So there are efforts to get to the point where we have vaccines for Lassa fever, which some of us believe is a game changer. We have thrown most of our response strategies to Lassa fever, and we think we are at the point where vaccine is really needed to stem the tide. So there are a lot of work that are ongoing. Maybe we'll encourage the partners involved in this to speak more about it. Maybe future webinar, we could bring them on board also to talk about Lassa research and vaccination efforts for Lassa fever. Thank you.
Yes, thank you so much, Dr. Banji. I think that's really well said. So I think just to elaborate further on the comments that has been made with regards to what's the role of the national TWG as well as state epidemiologists in this vaccine, because the person said, well, they are aware of ongoing efforts. So what's the role of the TWG, state epidemiologists? How much of our data is informing this process, and who are the key stakeholders? So I know the Coordinating Minister of Health and Social Welfare has inaugurated a task force for effective vaccine for Lassa fever. So there's already a team across the different MDAs in collaboration with NAFDAC, and the DG of NCDC is the chair of that group. And then the NCDC also serves as the secretariat for that. So in a few months, I'm sure we'll be hearing much more about that. But then, of course, we'll be happy to also put research and vaccine development as one of the webinars for this series. So colleagues, thank you so much for your questions. Thank you for also reaching out. And with regards to those that also asked about whether the slides will be shared. Yes, we'll share them. Apologies for not sharing the previous one. We'll work closely with our communications team to send the previous one and then this new one as well to colleagues. Okay, Favor, your hands are raised. You have the floor.
Thank you. I just wanted to bring the attention to one last question that has to do with sample collection with difficulties and resistance faced at the remote area. I don't know, maybe if I can just
yes, please go on. Please go on.
Yeah. All right. Thank you, Usman, for this brilliant question. So this is why we said surveillance activities, we encourage a One Health approach, right? So once you're going for case investigation and contact tracing or even active case search, you're going alongside with the risk communicators. Those people, they know how to, sort of narrow the message, talk about the dangers of not getting, not being sure of what you're dealing with in terms of the disease, and to know that for Lassa fever, if identified early, the chances of survival is actually really high. In 2019, in one of the high burden states, that would be Bauchi, we received a signal of a suspected death in a particular community. And from the symptoms and the story that we got from the signal, for us as healthcare workers and who has been on the field with lots of experiences, figured it was Lassa, but those are just mere speculations. So upon visiting that particular LGA, it was then I knew that there are different tribes, even within the house. I think they have like Fufu Day. So we went with the community informatics. We routed through the village head. So all of this courtesy visits, meeting the right persons is actually really key in Lassa fever response. Through the village head, first we were giving access to the community, and then identifying someone who the village respects and adores sort of. We went with an IC material of Lassa fever, specifically on the dangers where you have someone vomiting, bleeding from the nose and all of those. And by the time we were done with our sensitization, first we started with the sensitization before we even started with the case investigation. We now identified about 5 asymptomatic contacts and two contacts. The DSNO, some DSNOs, I know they have the skills of taking samples from suspects. And at the end of the day, we left that community with about, I think, 15 samples that was collected. Out of the 15, 6 of them were confirmed Lassa fever positive cases. So your manner of approach, the way you're also dressed, and the route through which you engage these communities is also very, very key. That's why we must use the One Health approach in Lassa fever response. I hope I've been able to address this question.
Yes, thank you so much, Favor. I know we're actually beyond time now. It was, scheduled 10 to 12, but just give us a few minutes and then we'll be done. I also remember there was a question with regards to elimination of the rats that have been known to be reservoirs for Lassa fever, but ecologically speaking, this will not be possible. And if we even try to eliminate them, we'll also be endangering the ecosystem because it needs to be balanced. But as much as possible, we'll control this population, whether within the hospital environment or households. But eliminating them completely is a no-no, and the animal rights activists will come for us. Okay. I don't know if there's any other question I've missed. I am not so sure. A lot of these questions have already been answered. Okay, Michael, I can see your hand up.
Yes, thank you. So I know if we try to read all the questions one by one, we might take forever answering the questions. So I wanted to just respond to a set of questions. There's questions that I asked about linking SOMAS with facility EMRs. Well, that discussion is still ongoing. So we hope in no time we could be able to link SOMAS with all local existing data capture systems, either in the facilities or wherever they are located. So this is to answer Dr. Ibezim that it's a discussion that's ongoing. He also mentioned what is the plan to train record officers in facilities on the use of SOMAS. So currently, we are deploying SOMAS to about 16 states, but we are focusing on secondary and tertiary health facilities currently. So I know persons that were invited for this training and mostly surveillance focal persons in the facility, I think some officers in charge, and also record officers in the facility. So we are taking it bit by bit to train health facilities personnel on the use of SOMAS. Currently, we are on secondary and tertiary facilities, and in no time we could cover, in a few months or few years, 1 or 2, we could cover all both private and public facilities in the country. Afiz also mentioned, what are we doing to involve all stakeholders? Like Dr. Abaye mentioned, the investigation and response to Lassa fever is a One Health approach: animal, environment, and the human sector. So we know that is not optimal at subnational level in some states, but like we say, we'll just keep pushing and keep having this collaborative discussion, mostly at the subnational level, to improve that system to fight this infection. So over from me.
All right, thank you. So Dr. Abaye, your final comments, or are you responding to a question?
Yes, just a few final comments. Can you hear me?
Yes, please go on, sir.
All right. So just to add that generally, many years ago, clinicians used to know a disease syndrome or an entity or group of diseases called pyrexia of unknown origin, which is PUO. In other words, fever of unknown origin. And this was because at that time, the one of the latest unknowns that had become known was HIV. So generally, they would say whenever you have fever of unknown origin, also test for HIV as one of the possible causes of the fever. But what we didn't realize at that time was that there were many other infectious diseases such as Lassa fever, viral hemorrhagic fevers, that were still going undiagnosed or misdiagnosed. So presently, because there is improved testing capacity for some of these diseases across the country, especially as we liaise with surveillance systems to pick up samples and send to reference labs, as long as we do that, many of these infectious diseases can actually be diagnosed. So it's just a general information to everybody and those especially who are seeing patients and handling patients, that you can liaise with the surveillance system to get samples tested for acute febrile illness patients. In other words, there should be an index of suspicion for acute febrile illness patients. Secondly, for clinicians specifically, we must remember our basic training in differential diagnosis. We should not just zero in on only one diagnosis all the time, as much as our experience and expertise will give us a high index of suspicion for one. We should not rule out the possibility of two or more others. And as a result, we should monitor our patients quickly. I believe that by the time a patient takes 2 doses of an anti-malarial, there should be signs of improvement, obvious signs of improvement. And if there isn't, then you should begin to think about other differentials such as Lassa fever and immediately liaise with the surveillance system to pick up samples and send to the relevant reference laboratories. So that's just what I want to add. And thank you all very much.
All right, thank you so much, Dr. Abaye. Thank you for sharing your wealth of experience over the years with us. So, Dr. Banji, I saw your hand raised earlier.
Yes, thank you. I think I've been trying to answer some of the questions in the chat in the Q&A section. So people can refer to them for additional context to some of the response provided. I think that's just what I want to share. Thank you.
Okay. All right, thank you so much. I think this then brings us to the end for this webinar series. Now it's time for the closing and wrap up. I don't know if Dr. Lois or Dr. Ladun is still around with us. Okay, so I can't seem to see them. Okay, so on behalf of the Director of Surveillance and Epidemiology, I want to deeply appreciate every one of us for joining this webinar series, for the fruitful engagements, interactions, the seasoned presenters, sharing their wealth of experience we've had for almost 55 years in Lassa fever control and management, and even more intensive efforts that have been implemented in the last 5 to 6 years now. So it's really a great pleasure to have you, and I'm sure you have thoroughly enjoyed every one of the feedbacks and the efforts that has been put into this session and presentation from our speakers. We are deeply grateful. And the next webinar series will be in another 2 weeks. And we hope that you also share widely within your network when that time comes. And we also promise to share the slides from the previous webinar and also this one. As long as you registered, that email address will be used to share the resource materials for further stepping it down, or also consistently reviewing it to update yourself with regards to control and management efforts. So thank you so much, colleagues. Enjoy the rest of your days. See you soon once again. And bye for now. Bye.